Welcome to All Home Care Matters, the show where we discuss all things home care, with discussions on important age-related matters and topics. Brought to you by Enriched Life Home Care Services, the #1 rated home care provider in Michigan by Top Rated Local.
Hello, and welcome back to All Home Care Matters. If this is your first time visiting us here at the show, we want to say thank you for taking time out to be with us today. We appreciate how valuable everyone's time is, and that's why we try and make each episode here at All Home Care Matters something that hopefully matters to you. Today, we are honored to welcome a very special guest, Beth Cavenaugh, who is a registered nurse specializing in hospice and also an author of the book, Some Light at the End. Welcome, Beth.
Thanks, Lance. It's so nice to be here.
And we love having you here. Beth, let's start real quickly here with, why do people need your book?
Well, I wrote this book for a number of reasons. I had my own experience with taking care of my mom when she died from lung cancer. And I was a new nurse at the time, so still a medical professional, but I had a lot of questions and I didn't really know what to expect along the way. So I was kind of surprised at every turn. And basically, I wanted to offer people a guidebook that they can use for patients and their caregivers while somebody is dying. I talk about hospice, what it's like to choose hospice, what if somebody doesn't want hospice. I talk about how people decline towards the end. I talk about pain and symptom management, and hopefully answer all the questions that people have while they're taking care of their loved one. And then I'm reminded of a story, Thelma and Louise, I'll call them. There were two patients that I took care of, and they were in the same room, separated by a privacy curtain, although you could hear and pretty much experience everything that was going on. And so Thelma's at the window and she's actively dying. So she probably has hours left. And Louise is at the the bed by the door. And she is doing pretty well. And she may even go home, we're not really sure, but she's on hospice, terminally ill. So Thelma at the window, she's got family coming in and out. We sent a chaplain in there to offer her final anointing. I was running in and out, managing her pain and her symptoms. And the gal at the door, Louise, she asked me, she said, "Is my roommate dying?" And knowing that in just a matter of hours, the funeral home would come and pick up her roommate, I said, "Yeah, she is dying." And she asked, "Is this how I'm going to die?" And I said, "Well, our hope is that everybody dies peacefully, that everybody's pain and symptoms are managed, that families gathered around, that their cultural and religious beliefs are honored and respected, and patients die peacefully. That's our goal with hospice." So I wrote this book because I really feel like if patients have this information and they know that that's what the goal is and that's how people can die, then they won't be so afraid of the process. So because it is a really scary process for patients and their families. And I just want to honor the process, but also present it just realistically and practically, but gently at the same time.
So one of the things that, with our profession, we deal with hospice patients and some that may qualify to be in hospice, but they may hesitate or they're not quite sure when hospice might be right for them. How does somebody know if there is a direct answer when it's time for hospice to be part of the care team?
Yeah, you guys have such an interesting vantage point, don't you? Like, you're already in the home before somebody's even close to dying. Their family, their life circumstances, probably what their goals are. And so it's so special, the work that you guys do. The home care it's a really tender place to offer healthcare to people. So just a moment of pause to honor the beautiful work that you guys do, really. And I think with hospice, it's not black and white. What's good for one patient with the exact same terminal diagnosis in the exact same time frame it may not be the right time for hospice for another patient. And a lot of that has to do with the patient's own goals and what they want and what's still meaningful to them. A lot of patients have a hard time giving up their familiar medical routines and their familiar medical professionals. I mean, probably like the caregivers that you guys are, the oncology nurses. There's not really a clear timeline. I was listening to your podcast from yesterday, about all the hospice stuff. I mean, you
Yeah.
give really good detailed information about the eligibility criteria for hospice and how it's very specific, when people actually qualify for hospice. So you need to actually be talking to the doctor, the healthcare professionals that you're involved with. I think generally I ask people when they're wondering if now's the time for hospice, I ask them to kind of zoom out a bit and look at their life circumstance. Like, how has it changed in the last 6 months? Has their quality of life declined? Are they going to the ER a lot? Are they spending too much time in the hospital? Are the treatments more harmful than beneficial? Really zoom out a bit and just kind of look globally at what's happened in the last 6 months. Have they lost a lot of weight? Is their appetite declining? And that will give you an indicator that, maybe this patient is declining, or maybe all the medical intervention is not providing your loved one with the quality of life that they want. So it's really a philosophical perspective, and it's going to require some ongoing conversations, honest conversations with the family and the medical professionals.
And I want to get your opinion on this. When families decide it's time for hospice, do you find that it's more at their urging or at the recommendation of maybe their doctor? Because, a lot of things that I've read working on different episodes we've done on hospice, not to the level of detail that you could provide, but a lot of things that we have found is that when the time comes that a doctor has recommended maybe thinking about hospice, that patient could have had it probably much sooner. But a lot of times doctors are so hesitant because they know almost what that means when they say that to that family. They almost feel bad or hesitant or reluctant to provide that recommendation. So the family misses out on all of the benefits that hospice could have provided them. So families are really urged and supported in saying, like you're saying, if you're noticing all these things, if you have these concerns, that don't be hesitant, because a lot of times we'll wait for a doctor to make the recommendation because they're the medical professional. But
Yeah.
the family's the ones that are seeing the things day to day and having to go through all of the difficulties and the pain and all of the other stuff that accompanies that. Do you think it's more recommended that you wait for the doctor to recommend hospice? Or if a family is identifying or even uncertain and maybe wants to ask, shouldn't they feel comfortable in going to their doctor and saying, what do you think about this? What are
I,
your thoughts on that?
yeah, I love that question. And I bet you really see when patients and families are struggling
Yeah.
and when they may benefit from hospice support. I mean, I bet you guys have, a really clear vantage point where you are. No, I think it's really great and empowering if families do kind of notice this decline or quality of life that we were talking about. To talk to their physician. I think bring up the conversation to their primary care physician, their oncologist, their cardiologist, who's ever really the main physician following. The other thing that you can do is call up a hospice in your area and ask them to come in for an informational visit. And usually, like what we do as nurses, we'll go into a home and we'll talk to the family and the patient about what hospice is, what it isn't, how it can benefit somebody, even if somebody doesn't qualify for hospice. It's just providing them information. And then the family and the patient can ask more questions. They can ask about that specific hospice and what kind of care they can provide. And they can also ask specific questions like, hey, my mom has lung cancer. Do you think she would meet criteria right now? And then they can go back and talk to the patient's oncologist, or, talk to their own medical director and gather up more information as to whether or not the patient meets criteria for hospice. So I think being empowered and being a patient advocate and taking the initiative on that conversation is a really good idea, Lance.
What happens when you have a patient, Beth, and they're on your schedule for hospice care and the patient's not ready for it? Does that ever happen where they might get admitted into hospice, or they want hospice but they're not ready? How do you handle those situations?
Yeah. I mean, I feel like most people aren't really ready for hospice because, I think most people aren't really ready to die. And and I know that there's definitely patients. I mean, this is according to Beth Cavenaugh, 20% of my patients might be ready to die when they sign up for hospice, meaning like they've really they feel like they've tried everything they could treatment wise, or they're done fighting, or they have had a very rich and full life and they're ready to die. Um, a lot of times I see patients not ready to die emotionally. And so hospice, we kind of anticipate that. And we provide a lot of emotional and spiritual support for patients at the end of their life, because they are processing the end of their life and what their life has meant all along and what's important to them right now, and what kind of relationship closure do they need, or is there any business they need to tidy up so they can have some peace, at the end of life. So I feel like we really anticipate that that's part of the process, that the patient's not really 100% emotionally ready and prepared to die and exit this earth. So yeah, it is part of our process. That's why we have this team approach. Thank goodness,
Speaking of the team approach, so who is part of the hospice team?
Yeah, there's the medical director, physician. Sometimes there's a nurse practitioner or physician's assistant. There's a social worker. There's a chaplain, a nurse, a home health aide. There's a volunteer if the patient wants it. And there is bereavement, which is grief support for about 13 months after your loved one has died, which can include counseling one-on-one, grief support groups. So,
Do you find that a lot of families take advantage of the bereavement counseling?
I don't know, actually. I think they do. I think the patients that do really appreciate the support groups and the remembering that happens, we like to get patients through that first year of birthdays, anniversaries, Christmases without their loved one, and just to feel like they have kind of, somebody supporting them and remembering their loved one in this first really difficult year. I mean, they're all difficult years after you've lost your loved one, but the first year there's a lot of difficult transition. So
What would you say are the most common symptoms that hospice patients experience, and how would that translate into your book being able to help them?
um, common symptoms that patients experience at the end of life are declining energy and mobility, difficulty swallowing and eating. There's pain, shortness of breath, anxiety, nausea, vomiting, constipation, confusion. Those are all common symptoms that we address. And my book really walks patients and their caregivers through this process of declining energy and mobility, and what you can do to anticipate that and prevent the surprises. So, like my mom, when she was dying, I remember one day getting her on the commode. And this was a day when basically she should have become bedbound. Like she was too weak to even stand. But I didn't really have that in my brain in that moment. All I could think of was getting her to the toilet. And so I really struggled getting her there. My mom really struggled, and it was kind of emotional and distressing to her, to have me get her to the toilet and then back to bed. And I just wish that had I known about declining energy and mobility ahead of time, that's when you think, oh, okay, we need a commode, we need briefs, mom will at some point not be able to get out of bed. And so then I could have maybe more gracefully said, mom, you're having a really tough time with your energy today. Your body's too weak to stand. How about if we just stay in bed? I've heard this happens. It might be just a rough day, but we can bring you a bedpan. The hospice people already told me about this, and this just might be an off day, and maybe tomorrow will be better, or maybe this afternoon will be better. But it's just anticipating all those details that come up, and they come up pretty suddenly. So I hope that my book can offer a resource for people. I also have a lot of information about medications that are used, because when caregivers are taking care of their loved ones, most of them are not trained medical professionals, and so they don't know what the difference is between lorazepam and morphine and Roxanol and hydromorphone. They all just sound the same when you're not in the field. And so I really laid out the kinds of medications that we use, and I explain why they're used. And I also offer non-pharmaceutical approaches to managing their symptoms, like anxiety and shortness of breath and pain. And I want families to feel more equipped with tools that they can use in that moment. As a nurse, I'll go into a family's home and I'll tell them all this information about pain management. And they only retain 10% in a normal state, and during grief and crisis, maybe 4%.
Right. Yeah. Yeah. They're already so overwhelmed with emotion and mental drain. I mean, it's a lot. It's a lot for them to take in at one time. Absolutely.
Right. I was wondering, does your organization, do you guys support patients during hospice?
Absolutely. Yeah. That actually, I was going to mention that when you were talking about hospice and the home health aide and the volunteer, we have found, for the majority, most hospice providers or in our area, they're very short on volunteers, first and foremost. That makes it very challenging and difficult. The volunteers can only provide so much certain support that they can help with. And then the home health aide, a lot of our families, when we're a part of it, a lot of times we're there prior to hospice. So we're starting, the family identifies an issue, and then over time, the issue becomes greater and the person's health and abilities decline greater. Mm-hmm. And then they find, okay, we're coming to an end of the road here. And so they bring hospice on board. Sometimes we'll recommend it or suggest it, or maybe at a follow-up visit, the doctor has finally mentioned, it may be time to think about it, or think about, palliative care, and then maybe transition into the hospice side, which I think would be great if you wanted to speak to that in a moment. And so we're there to the very end a lot of times. And we recently, actually, and I think you can appreciate this, a family that we were helping we'd been there for a couple of years. The daughter, we'd been suggesting to the daughter that her mother retain more help, because we were only there 2 days a week for a few hours, and the mother lived alone. The daughter, who was her, primary contact, lived 2.5, 3 hours away. And a lot of times the daughter would call and say, well, do you think you could stop by and just check on mom to see how she is? Well, it was fortunate. We didn't mind doing it. This wasn't a billable service. We just did it to try to help the family and to help the mother, because she lived alone.
Right.
And we would recommend quite often considering maybe increasing your mom's support that she has. The daughter one day called us and said, you know what, we're getting mom 24-hour care. And we said, that's fantastic. Yeah, hospice is going to be starting at the end of the week. And we said, well, and we're trying to explain to her, but you realize that doesn't mean hospice is going to be in the home 24 hours. Oh no. Yes, I talked to them. That's exactly what they're going to do. And, we didn't want to cause a conflict or an argument, but we're just like, well, that may be something new that they offer, but that's not our experience
Right.
as to what hospice provides. She said, well, I'm meeting with the nurse later today to get everything set up. She called us the next morning. I'm going to need you guys 24 hours a day. I misunderstood. Hospice is going to be over her care 24 hours a day, 7 days a week, but they're not going to be physically with her. So we became the eyes and the ears for this hospice nurse for multiple reasons. But one of the biggest ones was her daughter lived over 2.5, 3 hours away. So her daughter wasn't even aware of the day-to-day things. And we were just very, very happy when that took place, though, because this was a wonderful, sweet lady whose, health we just saw continuing to deteriorate, and her abilities. I mean, there were some days we would get there and she hadn't moved or changed her clothes since we were there 3 days earlier,
Right.
and we're trying to get this across to the daughter. But a lot of times, it's hard to have somebody see something if they're not ready to see it. And so I think it was just finally with the doctor. That's why I was bringing up that question. Is it usually at the family's recommendation or urging, or is it the doctor? And in this case, it was the doctor, because it had gotten so far to a point where I think the doctor finally said, I really suggest you, do a hospice assessment because your mom's health and, this and that. And, but she was thankfully, and something that we're always very honored by is when we can be there too for those last moments to try to make them as peaceful and comfortable as possible. And, this lady wanted to remain in her home, and she was able to do that with the support of the in-home hospice and with the support of the home care services, because she would not have fared well in a facility or, some type of rehab facility,
Right.
Yeah.
That's so lovely. I mean, that's one of my biggest issues with hospice. I'm a hospice nurse. I love it. I mean, I never want to leave it. It's just the most frustrating thing for me is how imperfect the system is, where people really do have this misperception that hospice comes in 24/7, and it's not that at all. I mean, it totals up to maybe 6 hours in a week where a nurse or a home health aide is in the home, maybe a chaplain, maybe a social worker total. But the remaining many, many hours in that week, the patient's either alone if they've been living alone, or they have caregiving support, or they have family and friends who are taking care of them. So, I mean, one of my things, which I don't do a lot of advocacy, but I can imagine doing more activism and advocacy later, or earlier. But I just feel like hospice needs to include caregiving services.
And we've, for us, we always say, every home health service, home health care, hospice, and then home care, they all play a unique role that the other cannot provide.
Mhm.
Home health care cannot provide hospice services unless you bring in their hospice division. Some places are strictly just hospice. Home care, we can't provide what the hospice providers or the home health care providers provide, but you can all work together. And that, I think, we were talking to somebody not too long ago. I think it starts in the doctor's office, because a lot of families have these myths and misperceptions about what each one of them does or doesn't do. We've had families who, had a loved one or a spouse with advanced dementia, and they were calling to inquire about information, and, the office would talk to them and provide them the kind of services and support we can offer. And then they'll say, but you know what, that won't be now, because for the next 9 weeks, we have home health care coming. Well, the home health care nurse or the home physical therapist, they're not going to be there, to help her get dressed at night, help her with her personal care, help with the nutrition. We can work together, or we can work independently. And I just think there needs to be better awareness of those services. And a lot of families, surprisingly, they're not even aware of home health care, and, so I think, there's a lot more awareness and work that could be done in helping to provide these resources to families. That's part of the reason we kind of started, All Home Care Matters, was just if anybody can hear some information that benefits them, then we've done our job. because there's so many families out there that they don't understand what home health care is. They don't understand. A lot of families don't know that hospice will come to their home. They
Right.
think hospice is a special building you go to in place of a hospital. And, all these, myths and, half truths and,
Mhm.
misperceptions. And then if they don't be made aware of it, then they just continue to go down the line, and they'll go to their women's group or their men's group or have a family meal at Thanksgiving, and oh yeah, we're gonna go to hospice. Where is it? Um, so there's a lot of help and support that families need, and that's what's so great about your book. Now, when you see somebody is getting close to passing, how do you identify that? Like, so a family, I can imagine, like myself, looking at a loved one, and if I'm not aware or know what to look for, that could cause, again, tremendous anxiety, and a lot of other things. How can a family member who has a loved one in hospice or even with a terminal illness, and they're there, how do they prepare themselves, and how do they know what signs or what to look for to know that maybe the time's getting closer? How would you describe that to a family?
I always say there's two stages of decline before somebody dies: transitioning and actively dying. And transitioning, okay, first of all, death doesn't occur like, I kind of lay it out neatly always how people generally die, but people die in very different ways all the time. So I just want to throw that caveat in first. People die quickly, they die suddenly, there could be a terminal event. I've been in the room with patients where I've just said, oh, they have hours to days. And then within minutes, they actively, like, they shift quickly and start to actively die. I've seen families come in the room and the patient begins to die. I've seen families leave the room and the patient begins to die. So I've seen many variations of how people die. In general, usually you can tell somebody's transitioning when they're less responsive, they're sleeping more often, they're really having a hard time getting out of bed, if at all. So sleeping more, meaning like 18 hours a day sleeping, not really responding as much, not caring as much about TV and eating and engaging with people, really just exhausted. That's generally what transitioning looks like. And when they're actively dying, they're non-responsive, so they're not engaging at all. So when you say, Joe, how are you doing today? He's not going to open his eyes. He's doing the work of dying. Their skin becomes a little bit cool and mottled. Mottled is kind of like a purpley bluish skin color that you can see on their knees generally, or on the places that are in contact with the bed, maybe their elbows or their heels. Um, Temperature fluctuations happen. They're unable to eat or swallow. So we start giving medications sublingually under the tongue. We just kind of wash out their mouth and keep it moist. Um, Patients will start to have a lot of respiration variations when they're actively dying. Sometimes they stop breathing for a minute or so. Sometimes they stop breathing for 15 seconds and then they resume breathing. And when somebody's transitioning, that's about a week to days away. And when someone's actively dying, it's usually hours to days. I mean, that's generally. And I always like to, I like this stage because it's a really pivotal piece of this process where you can bring people together and really have family be there. I feel really lucky that we can see these signs and symptoms that somebody getting closer, so that we can tidy up business and make sure their sister from Boston is able to call them on the phone and talk to them and tell them they love them. Or maybe we're waiting for their son Sam to fly down from Seattle. We just
Let me
there,
ask you that. How much do you, you hear over the years, I've heard people say, well, she waited for so and so to get there. Is that a real thing? Yeah. Yeah.
It's definitely a thing. I mean, it's kind of amazing. I think there's nothing's binary, but I think two things where definitely I've had patients wait and wait and wait, and finally the son arrives, and within hours to minutes the patient dies. I mean, it's kind of incredible because you're looking at this patient and you're thinking, how is this patient still with us? But it really is this kind of spiritual connection that needs to be tidied up before they die. And then I've also had patients who really want to die without family there. And it's a little more rare, meaning like I've seen it and I've had patients shake their head no, like please don't call my family. And because they don't want their family there when they die, they want to do it alone, or maybe they don't want their family to see them in that state. So I've had all different kinds of experiences, but I kind of like that. I do feel like relationship business is a really important piece to tidy up for people. You know, I think forgiveness, I love yous, thank yous, all of those things that you can do to manage your regret and manage the patient's regret. You know, what will the patient need to die in peace, and what do you need to live in peace? I think considering those questions are really important at this stage.
Beth, what can a family do who's watching or listening to this discussion? What could they do for a loved one when they are dying?
When somebody is actively dying, I actually have a list on my blog, I think, of
Okay. And we're going to put that in the description for everybody too.
yeah. And but it's a really beautiful time again to you can hold vigil, you can call in friends and family to sit with the patient when they're dying, so that, I mean, my hope is that nobody does die alone. But like I said, some patients don't really want families around, but if we have the opportunity to have people sit with the patient when they're dying, a lot of times people are uncomfortable because they don't know what to say, but I say silent presence is just as important as talking and answering questions. And, you know, so silence is good. Creating a calm, soothing environment, whatever that means to the patient. Sometimes it means having the news channel on. Sometimes it means, you know, having Bach playing in the background. Sometimes it's soap operas. So creating an environment for the patient that celebrates them and who they are and what they're all about and what's meaningful to them. Um, I think it's really important to still manage the patient's pain and any symptoms that they're having. And there's a list, again, I think in this same blog, about what to look for for pain if somebody can't articulate that they're having pain. Having chairs around the bedside, I think is important, so people can sit and be with somebody when they're dying. I think we're so afraid of this process, and it's really a beautiful, tender process if you can, you know, just take a breath and be there for some moments. And that's part of what I want for our culture, is to normalize and celebrate this life event. I think spiritually engaging, something that's important to the patient, whatever that means. It could be, you know, chanting or singing or a prayer or a poem, and just, you know, trying to finish up any untidy business. I had a patient who took a very long time to die, and we all just wondered, why is this patient? She had nothing to eat or drink for over 30 days. It was a slow death. And we found out after she had died, that there was family members that she was estranged from. And that caused her a lot of grief in her life. And that relationship business was never really closed up. But I feel like even if I had known that before, I could have enlisted the chaplain to maybe sit with her and offer her a prayer of forgiveness or a prayer of reconciliation, or, you know, some kind of moment of peace and sacred pause for this relationship, so that there could be some peace, you know. I think forgiveness doesn't necessarily have to occur with another person. It can occur internally.
Forgive yourself.
Yes,
Yeah.
forgiving yourself.
Yeah.
Yeah. Yeah.
Is there anything important to do after your loved one has passed? What would you walk us through that process?
Yeah. I mean, this is another thing I like people to think about ahead of time, because I mean, when my mom died, I was surprised. We were all surprised, even though the signs were there. We were with her. We thought she was dying, and then she died, and we were surprised. And we kind of just rushed through the next process, which was calling the funeral home and the hospice and getting her dressed, and then she was whisked away. So it was a jarring experience. So I do like it when patients and families think about it before the patient dies, and what would be an important sacred pause, whatever sacred means to you. So after somebody dies, like in our hospice homes that I've worked at and where I work now, we bathe the patient. If you're at home, you can just kind of freshen them up and, you know, comb their hair and put them in, you know, their favorite shirt that they, you know, always wore, or dress that they loved, or that they felt like they looked beautiful in. You know, placing flowers at the bedside or photos at the bedside, having a ritual, you know, a sacred ritual, a poem, a prayer, a blessing that would be important to them. Really having a moment, and it could be hours. You know, a lot of times patients and families feel like they have to call hospice right away after someone's died, but you can really take your time, take time that you need to honor, you know, I feel like even though the patient has died, there's still this spiritual presence that's kind of with us and around us all the time anyway. So honoring their body and honoring their soul in some kind of a way that will also give you meaning afterwards, because our grief process is long. And so if we can draw on these moments where, oh, I remember I bathed my mom after she died, or I sat with her and I cried, and my sister and I told stories about her. And, you know, you can really draw on these stories later on to help with your grief process down the road.
What is a way that your book can help somebody with their grief process? Do you have tips in there, or how does the book help with it?
I think that I had, you know, I had anticipatory grief with my mom when she was dying, and I wasn't expecting it. I flew down there to take care of her in California, and I was totally blown away by my own emotions that I experienced while I was being her caregiver. And, you know, you try to be up and happy and like everything's okay, and you're having this internal grief process that is, you know, killing yourself. Well, you know, I mean, I felt destroyed while I was taking care of my mom emotionally. And so a lot of it is empowerment and knowledge. Like I really advocate getting some kind of information so that you're not overwhelmed by taking care of your loved one. And a lot of hospices actually provide support and information. They have big binders with all sorts of information in it about the end of life process and all the medications that you're given. I also think, you know, throwing your expectations in the Lake Huron can help too, because I had so many expectations about how I was going to, you know, talk to my mom about the end of her life and what's important to her and what she wanted. None of that happened. You know, I thought the whole family was going to be gathered around, and we weren't. And so just throwing your expectations out, because I think a lot of our grief process comes from our expectations that may be unrealistic. And, you know, there's a lot of unforeseen activities that happen when taking care of someone at the end of their life. So I just hope that my book can offer there's a lot of moments of pause, and there's some reflections in there. And there's some, you know, a couple meditations or phrases that you can sit with that I really wanted people just to have some time. There's a lot of time in this process and open space when you're sitting at the bedside. And I just wanted them to have something they can hold on to and find some peace in this process and some moments of breath, you know.
So we like yourself, we encounter a lot of family members who have either been caring for a loved one and they get to a point where, they still have children that they're helping to raise, or, careers that are calling them back,
Yeah.
and they need that support. And we've had families who they just say, I am not able to do it myself. I cannot bathe my father, or I can't, I can't have that image in my head, or I just don't have the makeup for it. I want to be here as the son or the daughter, or as the wife or as the husband,
Yeah.
but they're still grieving.
Yeah.
So how do you grieve while also taking care of your loved one? Do you recommend people let your emotions show, or is it be strong while you're with your loved one for them, and then when you're in the other room, then you have your, time with your emotions and your feelings? Is there a right way versus a wrong way, or is it different for everybody?
I imagine it's different for everyone. And I don't, I definitely feel like it's not necessarily my area of expertise because I'm not a licensed counselor, social worker, but I do feel like, my theory is transparency is always good. And if you can be open about your own grief process and cry, you allow the patient to also have their own grief process. And if we can just honor and respect that we're all kind of in it, I think just being real about it can be the most beneficial, but that's based on Beth Cavenaugh's ideas of how to live. And then you brought up some things about people who are taking care of their loved one in the home and they're exhausted and they're at a point where they just can't do it as much. And I always advocate, if they can afford it, I have no idea what All Home Care Matters does in terms of, I don't know how much it costs and all that, but if people can afford, here in Oregon, people have to pay out of pocket generally for caregiving services. And I always say, if people can do it, it will be the most beneficial thing you can do for your loved one. So it's not like you have to have 24/7 care, but that way, like you said, they could be the daughter and not worry about bathing their dad. It's a very different relationship, right? When all of a sudden you have to take care of your dad and change his diaper and shower him. He doesn't want that. Most of them don't.
Right.
And also I think about like two 85-year-olds taking care of each other, where one has their own health issues and they're frail and they're trying to take care of their loved one. I've seen it so many times in the home, and it hurts my heart and my soul because it's not the way it should be. I know some people can do it, but it's really, you really do need 24/7 care at some point when you're on hospice. So, and with hospice, when somebody gets hospice, it's not going to be forever. So I always feel like if you can financially afford caregiving services and you think of it, I think I saw a statistic that people are on hospice an average of 89 days, which that's according to a Medicare statistic. And I feel like that's high. Most people sign up too late for hospice, in my humble opinion. So it's not going to be a forever time frame. So if families can afford caregiving service for a limited amount of time, then I feel like it would benefit everybody. You don't burn yourself out and you can just be your dad's daughter.
Yeah. Yeah. And ideally we hope, as I'm sure you do as well, that some point there will be added provisions or choices to Medicare to help provide for that in-home care. We have encountered over the years a case where a person was approved by their private health insurance for home care, and it was a special exception. And that was because they decided that financially it was more cost effective to allow her to have care in the home than it would be to place her in a facility.
Yes.
So, but and that was great for her. It was wonderful because it was a younger woman. But my question to that was, couldn't you make the same argument for everybody then, that you know,
Yeah.
but so whatever the reasons were behind it or whatever. So I'm hoping, you know, they do talk about the Medicare Advantage and these different things down the road. But, you know, it's not helping the families now. You know, I mean, I'm sure you encounter a lot of families who they're receiving hospice and they would absolutely benefit from, you know, professional services with home care in the home. But if you don't have long-term care insurance, if you don't have the financial assets to pay for it, and then, you know, the VA has aid and attendance, but then you have certain qualifiers for that as well. What does a person do? You know, it's really, you know, especially
Well,
with our population of baby boomers exploding year after year. I think 2039 or something, we're supposed to have the greatest number of, you know, 60 and over in the country. In our infrastructure, just for our healthcare system, can't support that number for all the people that are going to need beds. You know,
mhm,
we saw some of that with the pandemic, where they're building these makeshift hospital tents and bringing in, you know, these Navy hospital boats in, and you know, yeah. So hopefully at some point, you know, we will get some support for that, so that these families can get, you know, adequate care.
right. Adequate care. I mean, we want excellent care, but all we're asking is adequate care, right?
Right. Well,
I
and
mean,
I say that because where we're at, we're based in Michigan. Um, we're a non-licensed state.
mhm,
So what that means for families, and we do talks and educational things on this quite often, anybody in the state of Michigan could call themselves a home care provider,
mhm,
because there's no regulation. We don't fall under the Department of Health and Human Services or anything. And so we tell families, you know, when you're looking, and if you choose that for your long-term care or even your short-term care option, you go with a home care provider. Ask these questions, you know, do your homework, because there's no one else regulating it, you know, and that's the part that just terrifies us. We had interviewed the executive director of the Home Care Association of America about a month or so ago, and that was one of the things we were really talking about. You know, we're trying to make a strong push, the home care industry, so that all of the states are licensed and regulated, you
mhm,
know, so that there is universal licensing across the board, like there is for Medicare, right? The problem is you have 20 some states that are not licensed right now.
wow,
Well, now let's say one of the states gets licensed. That licensed state may have different requirements than another licensed state, you know, so you need it to be uniform across the board, you
right,
know,
right.
and hopefully one day that will happen. You know, we're big proponents of licensing, because, you know, this is too important of a need for these families to be just, you know, tossed to the side when, you know, you have companies out there doing it the right way and providing professional services, but you're almost in a way penalized because your state, there's no regulation.
Right. Yikes. Yeah. I'm glad you're working on that.
Yeah, yeah. So your book's in its fourth edition. Congratulations.
Yeah, that's because I didn't know. I wrote a book and I was like, I wasn't even a writer at the time. So, and then there's all these other pieces about writing a book that I had no idea about. So
Sure. Now, do you foresee like a fifth edition, and are you adding to it, you know, as you come up with different, you know, methods and ideas and resources, or?
no, not right now. No, I'm just trying to, I'm writing blogs about, I just want to get information out there for people, because I know most people struggle when they're taking care of a loved one at home at the end of life. And I get calls all the time from friends and family and friends of friends who just, ask me questions about it. And it's all the same questions. So I want information out there so people can feel empowered. I'm not working on a fifth edition. I am writing another book, but it actually has nothing to do with hospice.
Nothing to do with hospice. Okay.
Yep.
And they can find your blog and all these resources at bethcavenaugh.com.
Yes, that's right.
Okay. And we're going to put all of that in the show notes and the details, and we'll have links to the book, your blog. And I highly recommend families understand this and read it. Because like you mentioned earlier, Beth, it's a lot like long-term care, home care, in the sense that families don't typically learn about it, read about it, or understand it until they're in that moment of crisis. And now they really are left with no choice but to start finding out. And that's the last and worst time to try to find out about it. You want to better prepare. It's kind of like planning when you're putting together your will and things like that. Do it under a moment of calm and peace, not under a moment of pressure and crisis. And that's what we tell families all the time. Well, for us, we meet with families and, it'll be older siblings and, they were sharing the duties of caring for mom. Well, now, they're going back to work or, some of them are older. Now they have a health issue that's preventing them from doing it. And, now they're trying to figure out, well, how do we now take care of mom? Mm-hmm. And, so we'll meet with them and tell them different things. And, one sister or brother or whoever it is may decide, well, mom may need to just go in assisted living, but mom clearly is not a candidate for assisted living. So we're explaining, about assisted living and what options of care they will provide. And they may be good for people with suitable abilities and, capacities. But if it's somebody that is very dependent on one-to-one support and care, you may move her in and then find out quickly you need to now hire the extra support to provide that care. And we always tell them, make the decision and the choices when you can make them. Don't wait for something to happen where you may lose the ability to then make that choice. It might have been made for you. Right. So I think education for families is crucial. It's crucial, especially with things like hospice, because there's such a misnomer out there. I mean, we hear it constantly. One person said, well, I don't think I'm going to pass away anytime soon, but, they had stage 4, colon cancer. And well, but it may not be soon, but it may not be that long either. Right. Look into your options, because hospice can provide you so many other wonderful resources, even just the supplies for you that, you're not going to have to spend your money on, it can just, and it's going to also provide support for your family too, not just you, Right. So I think you're doing a great thing. I highly recommend people read the book and, ask those questions, visit your blog. I've been there a few times myself, and I think it's a great blog, and I really appreciate you doing what you're doing.
Yeah, thank you so much. I appreciate you doing what you're doing, because home care is the wave of healthcare, and, so I'm glad you're already entrenched in it and doing really good work, because it is going to be, people can't stay in the hospital that long.
Yeah. And statistically and personally, I personally have not come across anybody that would rather be in a facility than in their own home. Right. And I say, especially for the people with dementia, they are already got that ingrained in their long-term memory, where they're familiar and they know they're in a safe environment. And you take that person with advanced dementia or even moderate, and you put them in a strange building with strange people coming and going. It's terrifying to them, So, hopefully we can keep raising awareness and helping to spread information for families and the support. And like I said, we'll have all of your information in the show notes and the details.
Okay. Thanks so much, Lance.
You're welcome. You're welcome. We'll talk to you soon, and you're welcome back anytime.
Okay. Thanks so much. Have a great day.
Thank you for joining us today at All Home Care Matters. All Home Care Matters is here for you and to help families as they navigate these long-term care issues. We want to again extend our appreciation to Beth Cavenaugh, author of the book, Some Light at the End. Remember, you can listen to the podcast on any of your favorite podcast streaming platforms or watch the show on our YouTube channel. Just remember to hit that subscribe button so that you never miss an episode. Make sure you join us next time on All Home Care Matters, where we will be welcoming a very special, distinguished guest, leading dementia expert and champion from Australia, Tim England. This is an interview you won't want to miss.
Thank you for joining us today. We look forward to you joining us again on another episode of All Home Care Matters. To learn more about the show and to connect with us, visit us at allhomecarematters.com.